Good evening, everybody. Welcome to my YouTube Live. I'm Dr. Howard Elkin, the medical advocate, and this is American Heart Month. That's right, February is Heart Month. And so we're going to dive right into the most common cause of death and disability in this country, and that's heart disease. Now, I know a lot of you have kept up to date with COVID-19 and the death toll, which has been huge. I mean, I think we're up to 450,000 deaths in the United States alone as a result of COVID-19. However, heart disease still ranks as the #1 cause of death in this country. About 655,000 people die every year of heart disease. That's one every 30 seconds. Now let's talk about heart attacks for a second. Heart attacks, well, there's about 850,000 heart attacks occurring in the United States on a yearly basis. That's one every 40 minutes. So the statistics are pretty astounding, right? But what you might not know is that a lot of these heart attacks are silent, which means the patients may have no symptoms whatsoever. It's picked up by a routine EKG, or it's picked up later because the patient doesn't feel well. But it used to be thought that about 25% of heart attacks were silent. That's what I was taught when I was a fellow studying cardiology. But now, recent studies have shown that we're talking more like 45% of heart attacks are silent, which means there's damage done and the patient doesn't even know about it. So it's really important that we screen patients, we test patients, and we do everything that a medical advocate does to help prevent heart disease. Now, the way a medical advocate does is a little bit different than the traditional cardiology way. I mean, yes, we are interested in cholesterol lowering, but it's not about how low you can go. That's what a lot of my colleagues seem to think. I see LDL cholesterol of like 40, 30, 20. That's really low. And I'm not so concerned about how low you can go. I'm more concerned about your risk. So that's always my #1 question. What is your actual risk of heart disease? And that's what gets me going. So I have my little toolbox, and I pull these tools out of my toolbox. There's 4 basic tools that I use on a regular basis to help really assess the risk of my individual patients. #1 is stress testing of various forms. We'll get into that. #2 is advanced cardiac testing. #3 is coronary artery calcium scan. #4 is a new test that I am using called the pulse test, PULS. So let's talk about #1 first, stress testing. Now, when a patient presents with symptoms, chest pain, shortness of breath, palpitations, dizziness, extreme fatigue, I'm going to want to more than likely do a stress test on them. And that's really a physiologic test, meaning it's telling me how the patient functions. And it's still like the #1, it's not the cornerstone of assessing the severity of a problem. If a patient has a negative stress test, that's a nice thing to have. Oftentimes I don't have to go further. Sometimes I do. But it's always kind of the beginning if I'm really looking at a patient that I think may have a cardiac problem. There's 2 major ways that I do it. Both are with imaging. One is with an echocardiogram or an ultrasound. So we have the patient lie on a table, and we look at their heart function, the heart motion at rest. Then we stress them, and we put them back on the table, and we see if there's a difference in the way the heart contracts from rest and with exercise. If the heart's normal at rest and then becomes abnormal with exercise, we know there's a problem, and more than likely there's a blockage. I also do nuclear stress testing, which is the same type of stress test on a treadmill, but this time we look at we do a nuclear pharmaceutical. We inject intravenously in the patient, and we look at it before and after exercise. And we're looking for areas of the heart that don't light up with exercise. In other words, it's just not enough blood going, because the radiopharmaceutical is tagged to your red blood cells. So all of a sudden, if you don't see the radiopharmaceutical lighting up, that means there's a lack of blood flow. And that usually constitutes a problem. So that's how I evaluate a person who I think may have a problem. That's always going to be #1. And all doctors, cardiologists do that, whether it's traditional or integrative like myself. The next is advanced cardiac testing, really. Now, you all are probably aware of total cholesterol, HDL, LDL, triglycerides. Those are the average doctor orders. In fact, that's what the average cardiologist orders, because it's easy, it's easily accessible, it's inexpensive. but it's really not sufficient in my way of thinking. Now, you may know that LDL, we think of as, I have a little mnemonic, LDL is lousy cholesterol and HDL is healthy cholesterol. Now, it's not really as easy as all that. It's more complicated, but that's kind of a guideline. When you do advanced lipid testing, and I use two labs pretty exclusively because I've had great track record with them. One is Boston Heart Diagnostics out of Framingham, Massachusetts, and the other is Cleveland Heart Lab out of Cleveland. Now, Cleveland was bought by Quest Diagnostics about 3 years ago, so it makes it very easy to get this test done by going to Quest, but it is a Cleveland Heart Lab study. So besides those four, the simple lipid tests that you get, that any doctor gets, I'm going to look at LDL particle number. So we're not just looking at the LDL mass, we're looking at the number of particles in a blood sample. And a lot of people feel that that actually is a more significant prognostic factor for severe heart disease than just the LDL by itself. But I'm really interested in the size of the particle. So I don't care whether it's HDL or LDL. I want you to remember one thing: bigger is better. And I drive that home to all of my patients, because the larger the particle size, the less likely it is to become chemically altered and form plaque in the arteries. So we like large, fluffy, and not small, dense. And that these advanced tests will pick that up. It's also something called Lp(a), and little a is in parentheses. And that is a genetic trait, and you would not know what it is unless you order this particular test. It's a very sticky, inflammatory particle, which is correlated with pretty significant coronary disease. And again, you won't pick it up unless you do this test. So those are the major things that I am looking for. But then I'm looking at three other components that you get from this test. One is the inflammatory profile. Now, part of me says, I don't really care what your cholesterol is. I mean, I do, but I'm more concerned about, is there any inflammation present? Because inflammation is the bane of our existence when it comes to aging, whether it's heart disease, cancer, autoimmune disorders, or Alzheimer's. They all four have one thing in common: inflammation. Now, inflammation is not necessarily bad. It's actually our body's protective system when we are afflicted with a infectious disease or an acute illness. But when it's persistent, when it's chronic, when it's 365 days of the year, which I often see, it spells trouble. So there are four different markers that we usually look for. You've probably heard of C-reactive protein, or CRP. Every patient should know their CRP. It should be about as basic a test as doing a blood count or your electrolytes. Because if that's elevated, if it's greater than 1, you've got inflammation going on someplace in your body. We don't know where, because it's totally non-specific, but it's extremely important and a very sensitive sign. So yeah, I want to know, is there inflammation present? And then I want to look at your metabolic picture. Now, some of you may remember from one of my YouTube lives a few weeks ago, we talked about the 12% club. The 12% club means only 12% of the American adult population is metabolically healthy. That means 80% are not. And so that's why the metabolic component is very important. I'm going to look at whether you're pre-diabetic, a diabetic, metabolic syndrome. It gives me a lot of information about this whole metabolic picture, this metabolic milieu, And then there's also looking for a thing called homocysteine level. Now, homocysteine is actually it's a combination of amino acids that want to normally break down to cysteine and methionine. But if you have a genetic variant called MTHFR, which maybe some of you have heard about, you may not be able to break it down if that gene is switched on. And it's important to know because homocysteine levels that are elevated can lead to plaque of the artery. So it's another risk factor that is not usually checked for by most doctors and even cardiologists. Then the fourth component is the genetic component, and there's several genetic markers. This is a burgeoning field. It's a very interesting one, the whole field about genomics. So there's certain patients that have abnormal genotypes, and it's nice to know. And I'm going to give you a little example. I saw a patient today. She was 50 years old. Okay, now she doesn't really have bad risk factors. I mean, her cholesterol is okay. She's not a diabetic or pre-diabetic. She's a little overweight, but she does have autoimmune disorder called lupus. So she has perhaps some inflammation going on. But what ticked me off when I saw her about a month ago was that she had 2 significantly abnormal genotypes. I said, this is pretty abnormal. I better look into this. So I did a coronary calcium scan, which I'll talk about in a minute. And she's in the 80th percentile for her age group. It means she does better than only 20% of the women in her age group. even though she has no symptoms and she has few risk factors. She's got bad genes. That's why we use all these together to assess that thing called risk. Now, the number 3 on my tool in my toolbox is coronary artery calcium scanning. This is a simple CT scan. It's a 5-minute test. You go in there fully clothed, no IVs, nothing like that. And we actually detect the calcium in your coronary arteries. So there's 3 main coronary arteries. You want to see, do you have any calcium in them? Now, calcified plaque is one component of the plaque in your arteries. The other components are what we call soft tissue plaque, like a cholesterol and fats and triglycerides. So that's not detected by this test. So a negative test doesn't mean you don't have plaque. It just means you don't have calcified plaque. But we know enough, and there's a recent Western Denmark study. They studied like 12,000 people. And if you have a coronary artery calcium scan, a number of greater than 400, it does portend a worse prognosis. It doesn't matter whether it's 20% blocked or 60% blocked. It's just the total calcium burden is of significance and potential worse prognosis. And the last thing I want to mention is called the PULS test, PULS. It stands for protein unstable. I always forget this one. I'm really bad at the mnemonics like that, but it's a new test. It's a simple blood test. And it studies the plaque in your arteries. And it's not a visual test. It's not a scan. It's just a blood test. And it tells me, see, when your arteries get injured, so there's this lining throughout all your arteries called the endothelium. It's 1 cell thick. That's your protective barrier. As long as that barrier is intact, I don't care what your cholesterol is, nothing's going to happen. But because of smoking, high blood pressure, LDL cholesterol that's been oxidized, pollutants in our environment, poor sleep, stress, added inflammation, that endothelium gets disrupted. And then you have the formation of plaque, because what's happening, the cascade of, we call it the inflammatory cascade starts. So what we're looking at this test is, how does your body respond to endothelial injury? So the endothelium has been injured, and then your immune system in turn is being activated. Now, it can do it in a good way, or it can go overboard and do like a kind of like a cytokine storm, which you've heard about with COVID-19. So that tells me, so we get a thing called the PULS score. The higher the score, the worse the endothelial injury. The worse the injury, the more highly likelihood that you could have a coronary event, more specifically, heart attack or stroke in the next 5 years. So you get a score, and you get an actual prognostic number as to how you do compared to other people. So they're the tools in my toolbox, and I use them interchangeably. I don't always use all 4, but as you can see from my discussion, it's all about knowing your risk, not just about your number. So with that in mind, I want to bring this up to questions and answers, because I'm sure there's a lot of them. So I get my glasses on here and see. This is really small print, hard to see. Okay. I was just talking about this today. What does the basic lipid label really tell us? The advanced panel. Well, I think I answered that. So the simple, and most doctors still order that simple panel, because it takes too much time to explain all the stuff that I just did. It's not a 5-minute thing. I can't just say, oh, your LDL was really high. Your lousy LDL was high. So take this dose of a statin and we'll see you in 2 months. I don't work that way. That's not the way a medical advocate works. And I tell people I am an integrative cardiologist practicing functional medicine. And we start off my YouTube series in September talking about functional medicine and integrative cardiology. And that's kind of what I want to do, what I propose to do. Okay, thank you. Protein unstable lesion signature. Yeah, I'm really bad at memorizing the things. Okay. How concerned HDL particle? Okay. HDL, I like to call it healthy, but is it really healthy? And we used to think just several years ago that the higher the HDL, the more likely you would be protected from heart disease, because what it does, it's called reverse transport. It takes cholesterol remember, cholesterol it's not just flowing in your body, in your arteries. It's connected to a protein. So LDL takes it away it takes it to places like the brain where you need it, and also to the arterial walls where you don't want it. but HDL takes it back to the liver for clearance, and that's called reverse transport. And it's thought to be very protective. And they used to think the higher the better, but not really. Now they say if you have an HDL much greater than 80 or 90, it's not so healthy. It actually could mean portend a worse prognosis. We don't understand all that yet about HDL. I can tell you over the last 30 years or so, there have been at least 3 trials with drugs to see if we could actually increase the HDL level because it seems so attractive, right? But what happened, all these studies were stopped. The trials were halted because there was actually more deaths and more problems when we tried to actually increase HDL by number alone. There's something new called HDL functionality, which we're actually looking at the function of the HDL. It has not hit mainstream yet, but I think that will be important. I personally do think that there's some advantages to HDL cholesterol. We just don't, it's not as easily understood as we thought it was going to be. So stay tuned. We'll come back to that. Okay. Let's see. What genotype testing do you do? Okay. Now there's about 5 or simple genotypes that I do. I don't do a complete genomic study yet. It's really big. It's a burgeoning field, but as a cardiologist, I stick to what's really paramount in my field. So there's a couple that I think somebody in my audience from Dr. Spurko's work, like KIF6, KAF6, and 9p21. And don't ask me how these things got named the way they do, but if you have a positive gene from one or both parents, that does increase your chance of having coronary disease. And with KIF6, actually, these patients do better on statins, so that could be an indication for a statin. Then there's another one called APOE, which I'm sure many of you have heard of. And if you have one or both, this APOE 3 is normal, meaning you get 3 from one parent and 3 from another. But if you get 3 from one and 4 from another, or 2 4s, that's bad, and that increases your cholesterol, your tendency to actually hyperabsorb cholesterol. So if we have that gene, we may wish to give someone a supplement or a medication that helps to decrease the absorption of cholesterol. I will also tell you that it is the gene for Alzheimer's disease, and some doctors don't like to tell their patients that. Well, why not? All you have to do is go to the internet and look it up. So APOE is also a gene for Alzheimer's. So it doesn't mean you're going to have it. It just means you do have the genotype. So that's, and also a big one, the new one called 4Q25. And I really like that one because I'm seeing a lot of atrial fibrillation. As you know, that was the topic of my last couple of YouTube lives. And excuse me, it's the most common arrhythmia in those over the age of 75, but we see it in people of all ages. So there is a genetic tendency. It's something that's inherited. So again, there's 2 different subtypes that we look for. And if you have one or both, that will increase your chance of developing atrial fibrillation as you get older, if and when that gene is turned on. And the other one is MTHFR. I know what it sounds like, but I'm not going to say it. But it stands for methyl-tetrahydrofolate reductase. And there's 2 major types that we're looking for. One is C67.T and then A1298, or something like that. I don't remember these names. They're pretty hard to remember. But if you have 1 or 2 of these, that will increase your chances. That means you're a poor methylator. And these patients often have a difficult time breaking down homocysteine, which is a risk factor. It's easy to treat because these patients do well with B vitamins. Now, I have 2 copies of MTHFR, but my homocysteine level is always low, probably because it's just switched off for some reason. I'm glad that it is, but so these are the cardiac risk factors. Genetic factors that I look for. There will be more. This is a real burgeoning field, which is really exciting. Okay, what's most important for cholesterol and most important for inflammation when it comes to cardiovascular risk? Does it depend on the patient? Is it always the same? Okay, it always depends on the patient. Because I can have patients with bad genes. And remember, genes probably count for maybe 20% of your outcome. 80%, I think most people in the field would think is really lifestyle related. So it always depends on the patient in most cases. So inflammation to me is probably the most important thing. It really is the most important thing because remember that process that I described that's going on in the arterial wall, that's endothelial damage, that pulse test picks up quite nicely. And that's the crux of it all. If your immune system is activated to such an extent that that injury is huge and your body can contain it, that's going to increase your score and also increase your probability of having a heart attack or stroke in the next 5 years. So inflammation is always number one in my book. And of course, things like Lp(a) and these other genetic traits, and small particle size. I do a lot with small particle size. So, but again, as you can see, I use a multi-prong approach here. It's not just one or the other. And I look at them all and I give the patients, let them see what's going on, how they can help it. Okay, can someone get the Boston Heart? Yes, okay, in my office, absolutely. I've been working with Boston Heart for at least 6, 7 years now. Yes, I mean, you should be able to get it from anyone, but Boston Heart is a small lab, so you have to probably go to someone who does it on a regular basis, and they can refer you to a phlebotomist or a lab that Boston Heart contracts with. And it is covered by Medicare. Okay, that's very important. And it's covered by a couple of insurances, not all. So it's readily available. You just have to go to a doctor that does them. I've been doing them for a while, and also with Cleveland Heart Lab. So, like I said, most doctors do not offer these tests. You need to ask for them. If you're a medical advocate, you need to say, I want the Cleveland Heart Lab. I want Boston Heart Diagnostics. It's your right. Okay, let's see. I have a couple others here. Let me see. Okay, how quickly can someone reverse poor results? I would say within 2-3 months. What I normally do is let's say someone has small dense particle, which is unfavorable. Okay, and they also have a metabolic issue. They're like a pre-diabetic. I'll put them on. I usually always start with, first of all, lifestyle is very important, probably most important. So diet and exercise is going to be number one. And then I'll try supplements. Now, I'll be honest with you. If they have coronary disease or if they're diabetic, they're frank diabetics, I have to be more aggressive than that. And that's when I do use things like statins. There is a role for statins. So I use supplements when I can. But in the high-risk patient, I will use also a lot of traditional medications as well. But usually 2-3 months, usually by 3 months at the latest, sometimes within 2 months, I can start to see a change that's positive. Good question. Let me see if I've got everything else. We talked about. I have a couple other that okay, how concerned is HDL? Okay, we talked about HDL. Okay, let's say what else. I have a couple that someone wrote me, and let me get them out. Okay. Well, I think we've already answered this one. My doctor orders the standard lipid panel. Yet I've had both an MI, meaning myocardial infarction or heart attack, and a stent. Okay, there's no reason why a person that's had a cardiac history should not undergo more extensive testing. Again, you have to ask for it. You have to find someone who does this type of testing, because if you've had a stent, if you are diabetic, if you've had a heart attack or bypass, you're considered high risk by definition. So our goal in you is to prevent a second event, a second stroke, a second heart attack, a second bypass. My patients do really well, not because I'm so great, because patients that come to me want to do well. I usually attract that population of patients. So we work very hard on what's called secondary prevention, meaning we don't want to see a second event. So yeah, it's very important to do these advanced panels, especially in these kind of patients, to prevent further events. Do I really need both a coronary calcium scan and a pulse test? Okay, well, they tell different things. Remember, a coronary calcium test is going to tell me what things look like. It's going to tell me how much calcium you have in your 3 major coronary arteries. It's going to give me a number, and that number is going to it's going to tell me your calcium burden. It could be 50. It could be 150. It could be 1,050. We know a couple of things from the Danish study that if it's much over 400, it does increase. It puts you in a worse prognostic category. Um, and what I like about, I use Harbor UCLA because Dr. Matt Budoff does an incredible job. He's been studying this procedure for over 25 years. But they also have a very huge database of 30,000 patients. So let's say you have a level of, this lady today that I talked about, she had a level of like 20 or 30, right? Which is not very high. But because she's only 50 years old, when they compare her to other 50-year-old females, she's the 80th percentile. So it really helps to, prognosticate with and you're going against the population of patients in your age group. Is there an optimal cardiac diet? Well, that's a good one. This has nothing to do with testing. I'm always asked that. Yeah, the optimal cardiac diet is basically a low-carb diet. I'll make it easy for you. So I don't care if it's Mediterranean, paleo, ketogenic, or anything in between, or vegan. All diets, there's not one diet for everybody. We're going to have programs on diet coming up in the next few weeks. But basically, everybody should be on a low-carb diet because sugar is an anathema when it comes to inflammation. So when you talk about protecting the endothelium, what's the worst offending agent that can affect that endothelium in an adverse way? Sugar, carbs, starchy carbs. So I'm kind of in between Mediterranean and paleo myself. If I had a metabolic problem, I'd probably go more ketogenic, but fortunately I'm in the 12% club, so I don't need to do that. So it really depends on the patient. Okay, let's go for more here. What is the hardest number to reverse on the lipid panel? Probably the hardest thing is the Lp(a). Now, again, that is genetically determined. And all my young patients, I want to get an Lp(a) because I want to see what it is. Now, I will tell you that exercise and diet will not alter it. I don't care what you're doing. It won't change it. There's no medication for it. That's why doctors don't make a big deal about it. Believe me, if there was a medication for it, everybody would be treating it and everybody would be looking for it, but they're not. I use niacin with a fair amount of success. Niacin actually is vitamin B3. However, we're using it in much larger doses than we would for a vitamin. And it has been shown to be very useful. A lot of my cases, I can get Lp(a)s down. And one patient, I was able to get it drop 100 points, which is pretty significant with the use of niacin alone. Normally, you need use large doses, but it can work. Sometimes addition of fish oil will be helpful. Also, if you're a female, estrogen can help if you're in that pre-menopausal age group. So, but that is generally the hardest because there's no drug, no diet, no exercise program that will really alter it. So that's probably the most difficult one. Okay, let's see. How can we protect themselves from both sides? Oh, okay, side effects of treatment. Great. Thank you for that question. Okay, so let's look at statins because they're the most popularly used drug for cholesterol, and for good reason. They do really lower LDL, but they will make a small into a large, okay? So if you want to make a small into a large, statins aren't going to do it. Niacin can help. But the most common side effect that why people stop taking statins is because these myalgias, these muscle aches, this muscle weakness. I would say it's got to be in, the drug companies downplay it, but I would say it's got to be present in 20, 30% of patients. I mean, that's why patients will often stop a statin. So whenever, without a question of doubt, whenever I put a patient on a statin, I always add coenzyme Q10. And here's why. Statins work in the liver, and they work by decreasing a certain enzyme called HMG co-reductase. And that's very effective because when you reduce that, you reduce cholesterol production in the liver. However, that's the same system that the liver uses to make coenzyme Q10, which is very important for energy generation throughout our body, but certainly the heart has to work 24/7, and also for skeletal muscles. So that's very common. If you start depleting CoQ10, the skeletal muscles will feel it, and they will often get fatigued and cause pain. So statins can be very useful there. That's probably the most common side effect that I see. Okay, let's see. Would eating a big steak, a glass of water, 1,000 calories, eating a small steak and a glass of soda, it'd be worse for you. I don't worry about re-rate at all, to be honest with you. There are some people that have a genetic tendency, and you would get this with 24andMe or with Ancestry.com. If there's a certain genotype that you don't do well with saturated fat. But I'm not worried about saturated fat and heart disease because it's never been conclusively proven. I mean, I know if you read the Heart Association and you read all the literature from the 60s and 70s, they'll tell you that it's really bad because it's going to increase your chance of heart disease. It will increase your LDL cholesterol, but it can also increase your HDL, or healthy one, and it can increase the size of the LDL particle, which is also beneficial. So I'm not convinced that a big steak is going to hurt you. Of course, I would prefer that you do grass-fed versus, traditional kind of steak. But I'm not worried about red meat. I don't think anything too extreme is good. I mean, there's this new diet called a carnivore diet that some of you may have heard about, in which it's just meat and no vegetables. And this person that swears by this diet, first of all, if anybody tells you that their diet is the end-all, be-all, walk the other way, because there's not one diet for everybody, and I can promise you that. But it can be useful if people have a lot of GI issues, because it can cut down on gas and bloating and can actually help heal the gut. So for a temporary basis, I'm okay with that, but I could not eat meat every day of the week, nor would I recommend it. Any extreme like that bothers me. Okay, does the calcium score matter if there's been a recent I don't know if she means transesophageal echogram or whether you mean a TIA. Could you please, because there's TEE stands for transesophageal echogram, which I don't think any most people want because that's going down the esophagus. Okay. Does a calcium score matter if there's been no, it shouldn't reflect, it has nothing to do with it. A TEE is so most of the time we do echocardiograms with a transducer on the chest. We call that a transthoracic. Okay. But if we go to the esophagus, we're looking at specific valvular abnormalities that you can't really detect so well on a regular echo. And that's a more invasive procedure. It's like getting a gastroscopy, if I hear you right. Yeah, it should not really matter, Mindy, at all. Because again, the beauty of a coronary artery calcium scan is a 5-minute test. You're in there fully clothed. There's no IVs, nothing. You just lie there. So I don't think it would have any impact because a TEE, of course, is ultrasound. So I don't think it would hurt at all. Good question, though. All right, let's see. If you're having treatment for cancer, does that affect your heart health? Absolutely. Again, cancer is inflammatory, right? Inflammation in the making. I mentioned the 4 biggies: heart disease, cancer, autoimmune disorders, and Alzheimer's. So whatever we can do to combat inflammation, whether it's cardiac or heart, and they are often intertwined. I have patients that have both. It's going to help you. So again, fish oil. Fish oil is good for anybody over the age of 40. Turmeric is great. Ginger. These are your natural anti-inflammatory agents. There are studies that are being done with other with pharmacologic agents. I don't really recommend them for that particular use, but I will tell you that when statins came out in the 80s, when I was a fellow, it was like the best thing since sliced bread, because all of a sudden we could lower LDLs to really good levels. And we found out later, like out in the 21st century, that it really may do its thing by decreasing inflammation. It has an anti-inflammatory effect, which can be very helpful. We didn't know about inflammation when I was a fellow. Believe me, it never came up. So I've been in this field long enough to see that we've gone from just blockages getting worse and worse and worse and worse, and inflammation. So yeah, I think inflammation and cancer and heart disease go hand in hand. An anti-inflammatory diet. Okay, to me, an anti-inflammatory diet is vegetables, fruits, nuts. I think fish, and again, depending on whether it's fish, natural fish versus, wild versus farm raised. And also, again, the beauty of eating grass-fed beef is that you do have some natural omega-3s in it. So that's all anti-inflammatory. Diet is so important. Okay. Thank you for the love. Okay, let's see. I have a couple others that people have asked me here. Okay. My cardiologist totally disses supplements. Do they really have a role in prevention? Yeah, I think so. I've had patients come to my office with like 2 shopping bags of supplements. I'm saying to yourself, you must have the most expensive urine in the world because there's no way you can absorb all this stuff. And then I'll say, does your doctor know that you take all this stuff? Oh, no. If they knew that, they'd fire me. I say, okay, he'd fire you. And who's paying who here? if your doctor just supplements and you listen to me, or again, what I'm giving you are just suggestions and just their ideas, and they're based on my opinions. This is not to be taken to the point at which you should discount what your doctor tells you and do what I do, because if you're under someone's care, your allegiance is with them unless you make that breach. But you probably, if you believe in supplements, you probably want to go to a doctor that believes in them as well. If not, you're getting double standards, and it's going to put you in a bind. So I really suggest that it's a really important thing. Oh, here's a good one. This is true. I have a patient. The patient says, I'm on both a statin and Repatha. I don't know if you guys have heard of Repatha. It's one of those new PCSK9 inhibitors that you do subcutaneously twice a month. And it's a biologic, and it does an incredible job of decreasing LDL, like 70%. And a lot of people are adding that with a statin. So this lady tells me her LDL now is it's like in the 30 range. And her doctor says, it's perfect. And she asked me, is that a little low? I said, yeah, it is a bit low, because the studies of these new agents are very, very effective, and they will definitely decrease LDL to a great extent. However, is low the way to go, or how low can you go? And a lot of academicians, they're very brilliant cardiologists, believe that you cannot go low enough. So they've done studies with Repatha and Praluent, which are the two drugs that are out in the market now. I think there's a third one coming. And they've declared that no big deal. We've had studies up to 3 years. Doesn't affect brain function. 3 years? Okay, patients are on these drugs for like 20 years, 30 years, okay? And I don't know about you, but I don't want a good heart with a bad brain. And we need LDL cholesterol for the brain. It actually helps to generate new neurons, okay, nerve cells. It also helps with myelin sheaths, which helps you protect the nerve cells themselves. So personally, I don't like my LDL levels really, really low, but that is, you're going to see that with a lot of cardiologists. So again, my thing is to put this out there so you can do your own reading, your own research, which is what medical advocates do, so you can form your own opinions and do your own thing. Now, let's see. Okay, here's a great question. Once you have had recent, more invasive tests to view arteries, what a calcium score, any new information to a patient with a recent heart attack, failure, and a stent in the last month? Great question. I would not worry about doing a scan at the beginning, okay? If a patient's had all this stuff within a short period of time, meaning they've had an event, like a heart attack or a stroke, and they've had a stent or a bypass, no. I would first assess first of all, I would make sure that they don't have any ongoing pain. I would probably do a stress test within a couple of months of the procedure to get a new baseline, because the baseline before obviously has changed when they had a procedure or an event. So I want to make sure that they're stable. And then I'm going to go straight to the laboratory work that I've just told you about, because I want to protect that. I want to get them in the best shape possible. Probably a year later, I will do a coronary calcium scan. The scans, again, will only show me the calcium. And if you've had a stent or if you had bypass, you probably would do something called a CT angio, which is the same scan. However, it's a peripheral IV, and they're very good at detecting blockages in bypasses or stents. So once you've had an actually mechanical intervention, you would think a little bit differently. You'll still get the coronary artery calcium score, but the score is going to be grossly exaggerated just because of metal or any other anything in there, like an artery with the stent could have like a level of 600. And so it doesn't mean the patient's high risk. It just means the stent in that artery kind of blunts the significance of the scan itself. So again, I would maybe repeat something in a year or so down the line, but my emphasis would be on assessing the risk and doing everything I could to correct that, to minimize it. That's a great question, though. I think that's about it. You guys have been a terrific audience. And this marks the end of Heart Month. I wrote a blog, which is based on what we're talking about tonight, but it's a lot more detail. So if you're interested, you can contact us. And by the way, if you have if you have suggestions for further topics, please put them either in the chat box or actually you can in the comment section. Probably better in the comment section. We will look at that because I'm always looking for new ideas. I don't have like a set group of, just things always come up. They hit, and I like to talk about them. But if you have suggestions, please comment on them. If you're interested in the blog, go to heartwise.com. You can sign up. There's a sign-up page, and we'll be glad to send you a blog, which is kind of this material we went over tonight, but in a lot more detail. And again, remember, this is informational only. It's not meant to be written in stone. Whatever you hear from me should always be discussed with your doctor, because that's really, you don't want to withhold any information from your doctor. You want to find a doctor with whom you're comfortable, with whom you can take supplements if you want to, but again, you really should always run to your medical professional for that. Okay, we finish here. Have you heard that high HDL can actually not? Yes, thank you, Mindy asked that question. Yes, there's some controversy now that high HDL much higher than 80 is probably not all that great. We used to think, I used to have patients say, oh, I got an HDL 100, 110. Oftentimes, what I figured out, those patients were drinkers, and people that alcoholics tend to have really high HDL levels. I don't think they're healthy, but when I start seeing levels of 120 or so, that's a red flag in my book. So higher isn't, just like lower isn't necessarily bad, high isn't necessarily better. I think what's going to be really helpful, these new, we're looking into HDL functionality. There's something called coronary efflux capacity, CEC. And they're doing some really interesting testing on that now, but it's really not ready for prime time, and there's no standardization yet. But I would say in the next couple of years, we will be getting more information about HDL, and it will be helpful. I personally think HDL is a good thing, but we haven't quite defined what is the best thing about it. All right. I think we got it. Okay. Oh, yours is 100 and don't drink. Well, that's probably good then. I don't think it's necessarily bad. We don't know. It's just that we knew in previous years that the higher the better. And now it's thought to be much over 80 maybe isn't good. But I don't want to give you doom and gloom here. I would say I would look at all your risk factors, your family history. Again, I would do the advanced cardiac testing and go from there. Okay. All right, guys. Thank you so much. Happy Heart Month to everybody. And I'll see you in 2 weeks. And remember, please comment. If you see one of my videos, please do me a favor and like it, because through the algorithm here and YouTube, that does expand my audience, which is very important. And again, if you have further topics that you'd like to hear discussed, please put them in the comment section. And if you want to blog, go to my website. Thank you, guys. Good night. We'll see you in 2 weeks.